Okay, I think we are live. So, uh, good evening, everyone who's joining into this Pediatrics DNA quiz round two. So, the round one was already done in an online manner, and this is round two of the Pediatric DNA quiz. We are joined by some of the residents who are doing their MD Pediatrics or DNB Pediatrics. This is at DocTutorials. Every year we perform this DNA quiz. The purpose is to create an academic activity for all the pediatric residents and for them to understand how, different types of quizzes are asked to push them academically, to push them, mentally, and for them to have a brief, interlude, a brief interval, a brief break from their routine learning and routine bedside teaching that they are doing. At the same time, it is academic and it is based upon the latest protocols. So I'm Dr. Sandeep Sharma. I am pediatric faculty at DocTutorials. I've done my MT pediatrics from PGI Chandigarh, and right now I'm a practicing pediatrician at Chandigarh, as well as I am a clinician who teaches a bit. So I'm an educator as well. And I'm joined by the wonderful colleague of mine, the senior of mine, Dr. Aparna. Aparna ma'am is also, she's not just a product of PGI, she's also a product of AIMS. Ma'am, please introduce yourself.
Hi, everyone. I joined Dr. Sandeep in welcoming everyone to this quiz today. I'm a neonatologist. I work at Kim's Cuddles, Hyderabad, and I happen to have been a part of two very prestigious educational institutes. I did my MD Pediatrics from PGI and DM Neonatology from AIMS, New Delhi. And we happen to be a part of an academic institute running DNB Pediatrics and DRNB Neonatology today. So, really looking forward and excited to be part of this quiz, hosting this quiz. And believe me or not, hosting a quiz, you learn a lot. You may maybe as much or sometimes even more than what you would do as a delegate or a participant. I'm sure Dr. Sandeep would agree.
Surely, ma'am. Surely, absolutely. So basically, what we are going to do here is we are going to have this live quiz with some of the students with us. We have fine-tuned and selected four students who have performed well and who have topped in the initial rounds which were held online. There will be total of 6 rounds that we will be conducting. These 6 rounds cover different aspects of pediatrics. We are trying to make it as interesting and as clinical as possible. So, for those who are listening to it, you are most welcome to answer in the comment, because naturally there is a lag. So even if you answer correctly, there is no possibility that the candidate is going to answer immediately by looking at your answer. There will be 6 rounds. There is not going to be any negative marking. There is not going to be any passing of the question. And after the question slide is shown, the candidate will have about 10 seconds to answer it correctly. So, who are the candidates with us? I invite all of them to introduce themselves. We have already done the numbering prior. First, we have Dr. Anuja with us. Dr. Anuja, please introduce yourself briefly.
Hello, sir. I am Dr. Anuja Singhal from Meerut.
Okay, LLRM Medical College, if I'm correct.
Yeah.
Okay. Welcome, Dr. Anuja. Second, we have Dr. Bhairo Singh, who's student number 2. Dr. Bhairo, please introduce yourself, what place you belong to, and where you are doing your residency.
Dr.
Dr.
Bhairo Singh, you're on mute. You're on mute.
You're on mute. Please unmute yourself.
Sir, I am also from Meerut. I have also done my post-graduation from LLR Medical College, Meerut.
Okay. And Dr. Bhairo, we can barely make out your contours of the face. So a bit of lighting would do well, but it's okay. It's okay. If
Sir,
there's some electricity issue, then it's okay. Fine.
yes, sir, electricity issue.
Light game. So third, we have Dr. Mrityunjay with us. Dr. Mrityunjay, please introduce yourself.
I am Dr. Murtunjay Sahu, doing the secondary DNB third year resident at Tata Main Hospital, Jamshedpur. I am from Odisha.
Okay, great to have you here. And fourth, we have Dr. Rohan Singh Negi. Dr. Rohan.
Good evening, sir. Myself, Dr. Rohan Singh Negi. I am doing my PG residency from GMC Haldwani, Uttarakhand.
Okay, nice. So we have all these four people who have introduced themselves. Without wasting any time, I think it's time to start the quiz. So we will be, I'm going to share my screen. And
Should we go through the rules quickly?
Yes, yes. Ma'am, please summarize the rules while I'm sharing my screen.
Yeah. So we're going to have 6 rounds totally today. The first, third, and fifth round would be done by Dr. Sandeep Sharma. And these are going to be on general pediatrics, systemic pediatrics, and on syndromes, respectively. The second, fourth, and sixth rounds would be done by myself, and these are going to be on neonatology, a visual round, and the last round would be a rapid fire. So for all the first 5 rounds, we are going to have a single question directed to each of the participants. Each of you would have 10 seconds from the time the question is completed by the faculty, and you can give one final answer. Please make sure that you do not give multiple answers. The first answer would be counted as your final answer. If it is right, you get 10 points, and if it is incorrect, you don't worry, you don't get any negative points. And since this is a virtual quiz, you don't have the option of passing the questions to the other participants. Some of the questions are going to be a direct questions and just an answer, and some would be in the form of multiple choice questions. The rules remain the same for both these formats. Now, with regards to the rapid fire, we would have a set of 5 questions to each of the teams. And again, we wouldn't have the option of any negative marking. So there would be a total of 30 seconds for the rapid fire from the time that we start the questions. So you can answer as many questions as you're able to complete, but do make sure that if you have given the wrong answer, you do not have the option of coming back to that question. If you're not sure and you still want to come back to the question, you can say pass. Then we will come back if we have time and read the question again, and you have the option of thinking and giving the answer. Each of the answers will carry 5 marks in rapid fire. So if you answer all 5 out of 5 questions right, you can score 25 marks in the rapid fire. So that's it. If you have any doubts, you can quickly clarify.
Any doubts, please let us know. Okay. My advice,
Request the DocTutorials team
everyone, please,
to keep the
please keep.
time. So it's going to be 10 seconds.
Yes. I think everyone should keep themselves mute except
Please
me and
mute your audios.
me and myself. We will keep ourselves. And the student whose number comes, then they are supposed to unmute themselves, and then we will be starting. So
Yeah.
I
So
think we are
someone from
good to go.
DocTutorials would kindly indicate when 10 seconds is done. Yeah, Karthik can probably just indicate the 10 seconds done whenever the time
Yes,
is
ma'am.
over.
Yes, ma'am.
Yeah.
Karthik, you have to
Count from
just
the time that we finish.
just
Yeah,
announce
I'm,
that time is over, right?
yeah, sure.
Okay.
I'm on it.
Okay. So let us start with round number 1. And Dr. Anuja, please unmute yourself. This is a clinical scenario round. Basically, we have questions taken from the general and systemic pediatrics part. So look at the scenario. Think about it. There will be 4 options. One of them will be the correct answer. You have to figure out the best answer among the options given to you. Okay. So, Dr. Anuja, are you ready? Should I start?
Yes, sir.
Okay. Question number 1. There is a 3-year-old child who presented, as you can see in the image, 3-year-old child who presented with intermittent episodes of photosensitive rash, diarrhea, and ataxia. There is a history of similar episodes triggered by illness. Urine amino acid analysis shows neutral amino acid urea. What is the most likely mechanism of this clinical condition? 4 options are there: defect in tryptophan absorption, defect in phenylalanine metabolism, impaired urea cycle, and defective fatty acid oxidation. Your time starts now.
Five seconds.
Option A.
What is your correct answer?
Time up.
A.
Yes, she has answered within the time limits. Before we show the answer, look at what the question is telling you. Photosensitive rash, diarrhea, ataxia, triggered by illness. Second important clue is neutral amino acid urea. Whenever you have a photosensitive rash, diarrhea and CNS involvement, we are thinking of a pellagra-like rash. But pellagra does not have neutral amino acid urea. Ataxia is rare. An intermittent history of triggering by illness indicates it is a metabolic disorder related to it. The metabolic DD of pellagra is Hartnupp's disease. And Hartnup disease has a problem of neutral amino acid transport. So A is absolutely the correct answer to this question. So answer to this question is A, defect in tryptophan absorption, and Dr. Anuja gets the full marks. She gets full marks. Karthik, please keep noting. Dr. Anuja gets full. Yes, she gets full 5 marks on this
Done, sir.
question. Okay,
Noted.
noted. Thank you. Second, we move to Dr. Bhairo. Dr. Bhairo, please unmute yourself. You ready?
Yes, sir.
Okay, I'm just showing your question to you. Your question comes up here. A 7-year-old boy diagnosed with ADHD has significant inattention and hyperactivity affecting school performance. Behavioral therapy has been inadequate. The child has a history of mild tics, which is the most appropriate pharmacological option in this child. 4 options are given: methylphenidate, atomoxetin, amphetamine salts, and haloperidol. And your time starts now.
5 seconds. 4, 3, 2.
Option B, atomoxetin.
Atomoxetin. So B is your answer, and B is the absolutely correct answer to this question. This is an ADHD patient. Generally, in ADHD patient, methylphenidate is considered to be the initial therapy. But whenever there is a tic involvement, or suppose there is a cardiac disease where stimulants cannot be used, you have to go for atomoxetin. So remember the key funda. Very similar question. Very similar question has been asked in NEET super specialty exam a couple of years back as well, where they had put case scenario. Remember, in ADHD, generally we prefer methylphenidate, but there are scenarios like CVS involvement, like tics, where atomoxetin becomes the default drug of choice. So absolutely rightly done. So you get full credit to this. Bablu, please note the
Yes, sir.
answer.
Noted.
Yes. Next, we move to Dr. Mrityunjay. Dr. Mrityunjay, are you ready?
Yes, sir.
Okay. So your question comes up now. Question number 3, I'll say it out. 6-day-old term neonate brought with poor feeding, vomiting, and lethargy since day 3 of life. The baby was started on exclusive breastfeeding soon after birth. The infant on examination is icteric with hepatomegaly and appears septic. Lab reports show total bilirubin 14 milligram per deciliter. It is indirect bilirubin. AST, ALT are elevated, and there is non-glucose reducing substances present in urine. What is the next step in management? 4 options are given: continue breastfeeding and start IV antibiotic, switch to lactose-free formula and start IV antibiotic, start phototherapy with sepsis screen, and begin exchange transfusion after ruling out galactosemia. And your time starts now.
Sir, well, option B.
Final answer?
2, 1.
Okay. Answer number B is correct answer. This is a child who has got likely galactosemia. Galactosemia, the classic galactosemia generally presents within the first week of life, intermittent vomiting, poor feeding, lethargy, which becomes more persistent as the baby feeds. There is liver involvement, there is hyperbilirubinemia, and non-glucose reducing substances on Benedict's test is the clue. Serum galt activity can be done, and E. coli sepsis is particularly common in them. So you have to switch to lactose-free formula, and for the likely E. coli sepsis, you have to start every antibiotic. So B is absolutely correct answer. So you get full credit here as well. Fourth, we have Dr. Rohan Singh Negi. Dr. Rohan, are you ready? Should I
Yes, sir.
show the question? Okay. Dr. Rohan, your question comes now. A neonate presents at 12 hours of life with severe cyanosis, SpO2 68% on room air, and improves minimally to 72% with full oxygen. Heart sounds are normal, no significant murmur. X-ray shows a narrow mediastinum. Echocardiography confirms it is a TGA patient. There is intact ventricular septum, small patent foramen ovale. He had one episode of apnea during echocardiogram. What is the most appropriate next step in management? 4 options are given. Start IV prostaglandin with low threshold for intubation. Immediate arterial switch surgery since PGE1 cannot be given owing to apnea. Pulmonary artery bending after giving PGE1 for 12 hours under intubation of the child. And urgent switch surgery immediately is the 4th option. Look at these 4 options. This is TGA patient. Longer question, but your time starts now.
Sir, A. Start IV prostaglandin E1 infusion with low threshold for intubation.
Okay. So A is your correct answer?
Yes, sir.
A. A is your correct answer. And the correct answer to this question is A. See, in this question, this is a TGA patient. And TGA patient, because there is an intact ventricular septum, so this is a ductus-dependent congenital heart disease where there is a parallel circulation happening. Due to this parallel circulation, the patient is not improving. And although apnea sometimes can be a complication, but single episode of apnea is not a contraindication for prostaglandin. You have to start prostaglandin. You have to intubate the patient. Low threshold should be there. Already one episode of apnea has happened, and following which you can take a call that whether you should go for Rashkind atrial septostomy. These days direct surgery is also being undertaken in tertiary care centers wherever it is possible. So answer to this question is start IV prostaglandin infusion and always keep intubation apparatus ready. Apnea, fever, etc. are very common in these patients. So fourth is correct, and I'm quite happy to know that most all of you have answered full credit in this round. So round one, it was more of a testing round. It was more of a warming up round. But I'm quite happy to know all four of you have done excellent. So at the end of round one, all four stand at the same scores. Over to you, ma'am.
Dr.
Thank
Mrityunjaya,
you,
we
Dr.
request.
Sandeep.
Aparna, I'm
Yes,
sorry to interrupt in between. Dr. Mrityunjaya,
Yes.
please avoid speaking to someone. It's a request.
All right. We'll now go over to the first round of neonatology. I'm just requesting that I be allowed to share the screen. Is my screen visible to everyone?
Yes, ma'am.
Yeah. Okay. So this round is going to be on case-based discussion in neonatology, and some are non-case-based as well. There will be 10 seconds again from the time I finish reading the question, and if you get it right, you score 10 marks. So all the best. Let's begin again from Dr. Anuja. Are you ready?
Yes,
Anuja.
ma'am.
Dr. Anuja? Sorry, Dr.
Yes,
Anuja?
ma'am.
Yes, please unmute yourself. So a 12 weeks primary mother is having rash with thrombocytopenia and she is detected to have toxoplasmosis. What is the drug of choice for maternal toxoplasmosis before 14 weeks of pregnancy?
Your time starts now.
Time begins now. Yep.
Ma'am, spiramycin.
Excellent. Very good answer, Dr. Anuja. It is indeed spiramycin. So you all know that the other drug that is used for the treatment of toxoplasmosis is a combination of pyrimethamine, sulfamethoxazole. But because of its potential teratogenic effects, in the first trimester of pregnancy, the preferred drug for treatment of maternal toxoplasmosis is indeed spiramycin. The maximum chance for fetal infection happens in the first trimester, but the maximum chance of teratogenicity is actually going to be in the first half of the pregnancy. I'm sorry, the maximum risk of transmission, however, happens between 16 to 24 weeks. That is in the later half of pregnancy. But the infection in the first trimester is more likely to be associated with the teratogenic side effects or organ involvement. So spiramycin, right answer. We can give 10 marks to Dr. Anuja. So
Ma'am,
next,
10 or
Bhairo,
5?
are you ready?
Ma'am,
Yes,
sorry,
ma'am.
10 or 5?
Yes. Your question? A term baby presents on day of life 3 with vomiting and decreased activity and suspected inborn error of metabolism. On examination, the baby is having seizures, apnea, and hyperventilation. Blood tests reveal respiratory alkalosis, whereas glucose and ketones are normal. The serum ammonia is elevated at 800 micromoles per liter. Citrulline levels are markedly high, and ASA, arganosuccinic acid levels, absent. What is the likely disorder you're dealing with? Your time starts now.
Then
5.
citrullinemia type 1, ma'am.
Time up.
Can you come again?
Yes, ma'am.
Can you please repeat your answer, Dr. Pyro?
Citrullinemia type 1, ma'am.
All right. I think we can give you full marks. Citrullinemia is indeed the right answer. This is a type of urea cycle disorder. So you could make out that this baby had a urea cycle disorder because the baby had respiratory alkalosis, hyperammonemia, and the baby had the classical presentation with seizures, apnea, and hyperventilation after gradual building up of breastfeeds, which is classical presentation of IEMs, and urea cycle disorders particularly are known to present with alkalosis, increased ammonia levels. And in this condition, you got additional clues that the baby had citrulline, which was markedly high, and ASA that was not present. So this is classical of the third step of urea cycle disorder enzyme defect, which is citrullinemia. You did say type 1, that is not something which was part of the answer that is expected, but since citrullinemia was close and you were able to hit right on the name of the urea cycle disorder, so we'll give you full 10 marks for this answer. Well done, Dr. Bairo.
Aparna,
Dr. Mrityunjay, are you ready?
Aparna, ma'am, one
Yep.
second. Dear sirs, requesting not to take the eye contact from the screen. Whenever you are answering to the ma'am or sir, we request you not to take off the eye contact from the screen. Thank you. Ma'am, please continue.
All right. Mrityunjay, please unmute yourself and be ready for the next question. In suspected NKH, non-ketotic hyperglycinemia, what is the classical diagnostic test that clinches the diagnosis biochemically? And your time begins now.
Non-classical test that clinches diagnosis.
5, 3.
Reducing sugar.
I'm sorry, I don't think we can give it to you, Mrityunjay. I heard reducing sugars. I'm sorry, that's not right. You do use urine reducing substances for for evaluation of conditions like galactosemia. Again, that doesn't clinch a diagnosis of galactosemia. The diagnostic biochemical test for NKH is elevated CSF glycine to plasma glycine ratio. So NKH is one of the deadly inborn errors of metabolism that can present very early on in a newborn with the classical IEM presentation in the form of seizures, encephalopathy, shock, and very often can result in catastrophic complications. And very importantly, this condition may be associated with a normal ammonemia, normal lactate, and negative urine ketones and normal glucose levels as well. So it's often difficult to find these early biochemical derangements that we usually expect with an inborn error of metabolism. However, the diagnostic biochemical test is an elevated CSF glycine. And more specifically, we look at CSF glycine to plasma glycine ratio, which must be more than 0.08 in order to clinch a diagnosis of NKH. So I'm sorry, we'll not be able to give this marks to you. The classical clinical symptom of NKH happens to be hiccups, and you may often find burst suppressions if you do an EEG in this baby. The next question is for Dr. Rohan. I hope you are ready. Please unmute yourself.
Yes, ma'am.
A neonate with hypocalcemia with a serum calcium of 6 milligrams per deciliter has mildly elevated phosphorus and elevated PTH, parathyroid hormone. What is the most likely diagnosis? Your time begins now. Low calcium, high phosphorus, and elevated PTH.
5.
And kidney, the chronic kidney disease in a patient, AKI can be there. AKI.
Okay, I think we can give it to you. I heard chronic kidney disease versus AKI. AKI less likely, but chronic kidney disease is one possibility. There were two potential answers for this question. You could have either had pseudo-hypoparathyroidism, which is a receptor defect for parathormone, where you would find hugely elevated PTH levels, and however, because of the receptor defect, the baby would still manifest with all the symptoms and signs of hypoparathyroidism, which would include hypocalcemia and hyperphosphatemia, which this newborn did have. The other option, the other answer that you said is also right. Renal failure, especially chronic renal failure, because that will give sufficient time for the elevation of PTH hormone. Now, when would a newborn baby have chronic renal failure? One of the reasons could be an obstructive uropathy, where the baby has, say, a condition like posterior urethral where the baby had antenatal, obstruction to the renal system. So that could be a potential reason for elevated creatinine, azotemia, and symptoms of CRF. And such babies can also have this kind of metabolic derangement. So we'll give 10 marks to Dr. Rohan. So I also have an additional question. I think I'll just leave this as an open question. None of you get marks for answering this question. Any of you are open to answer this question, of course, with the exception of Dr. Sandeep. In a baby with suspected DSD, disorder of sexual differentiation, what does anogenital ratio indicate? So Rohan, Mrityunjay, Bhairo, Anuja, anyone wants to attempt? You don't get negative marks. You also do not get marks for answering this question. This is just an extra question. No takers. So anogenital ratio is the ratio of the distance from, as you can see in this figure, from the anus to the posterior fourchette divided by the distance from the anus to the clitoris or base of the phallus. So the greater the ratio, it indicates greater is androgen exposure or the extent of virilization. So this is an indicator used to understand the extent of virilization in a newborn with disorder of sexual differentiation. So we are done with round 2. I hand over back to Dr. Sandeep, and maybe we can have a quick round of scores until now.
Yeah. After 2 rounds, Dr. Anuja is on 15, ma'am, and Dr. Bhairo Singh is on 15. Dr. Mrityunjaya, he is with 5, and Dr. Rohan Singh, he is with 15.
Okay. Thank you, Babu.
One doubt, how did they score 15? I mean, they either get 10 or 5, 10 or 0, isn't it?
No, ma'am.
Yes, ma'am.
The round 1 had score of 5 only because it was the easy round. It was easy.
Okay.
Yes.
Got it.
Now it will be 10
All
marks each. So it will now pick up. According to the round also, in your case, all the 3 rounds, they are 10 marks each. In my case, it is varying. So that is why the difference in score is there. So actually, student number 3, Dr. Mrityunjay, is down only by 1 question. So even if the score may
Right.
seem to be very heavy, 1 question correct and others don't get it, he will be back in the game. So he's definitely back in the game right now also. So let us move over to the next round. This is a round related to pediatric emergencies. Now, in this round, let me be clear, there is not going to be any option. Just like ma'am was showing the question, there will be a scenario. I will say out the scenario, then you have 10 seconds to answer, and you get 10 marks for this round. So this is one round where you can score, better off. And first of all, we start with Dr. Anuja. Dr. Anuja, you are ready?
Yes, sir.
Okay. So question number 1 is on your way. Look at the question. A 6-year-old child presents with sudden onset urticaria, respiratory distress, and hypotension 5 minutes after eating peanuts. On examination, blood pressure is 70/40, heart rate is 140 per minute, SpO2 is 88%. What is the immediate next step in management? And your time starts now.
So
5.
we can give epinephrine.
4.
You have to tell either the dose or the route and, of everything as well, because that is
Intramuscular we will give epinephrine.
correct. Absolutely right. You have to give epinephrine intramuscular in anterolateral thigh in a 6-year-old child. Reason being, it is anaphylactic shock. Now, many times when children come to you with hypotension or in a shock kind of a state, people have a tendency to rigidly follow ABC. Here, you have to maintain that airway is patent. There doesn't seem to be anything wrong with the airway. You have to manage anaphylactic shock, and in any suspected anaphylactic shock, intramuscular adrenaline has to be given immediately. So absolutely correct. You get full credit, 10 marks in this round. So Bablu, please note, she gets 10 marks. Second, we move to Dr. Bhairo Singh. Dr. Bhairo, you are ready?
Yes, sir.
Okay. So your question comes up. now. A 2-year-old child is brought with complaints of sudden onset coughing and breathing difficulty while playing with peanuts. Again, peanuts are here. On examination, the child is conscious and anxious. Respiratory rate is 42 per minute. SpO2 is 92% on room air. Air entry is reduced on the right side with localized wheeze. There is no cyanosis. Child is able to cry. What is the most appropriate next step in management? And your time starts now.
5, 4,
Sir,
3.
urgent rigid bronchoscopy, sir, is a obstruction.
Time up.
Done. Absolutely correct. This is a child who was playing with a suspected foreign body. There is no choking present, and there is no, child is able to cry. There is no absence of sound production, no cyanosis, means it is not stuck in the larynx. It has gone down. There are two types of foreign body aspiration we need to be watching out for. If the question says the foreign body is stuck here, the child will have inability to produce sound, choking, gagging, and cyanosis appearing in the patient. You have to perform urgent maneuvers like hemorrhage maneuver. But if the foreign body goes down into the bronchus, you will have, distress happening, but there will be unilateral wheezing, unilateral hyperinflation on X-ray, and air entry will be reduced on the right side. X-ray is not mandatory. You have to do rigid bronchoscopy because it is both diagnostic and therapeutic. So arrange urgent rigid bronchoscopy for the removal of the foreign body. So he gets full credit. Moving over to Dr. Mrityunjay. Dr. Mrityunjay, you are ready?
Yes, sir.
Okay, let us see the question that you get. Question number 3. A 4-year-old child is brought to the emergency department with generalized tonic-clonic seizures lasting for 8 minutes. There is no history of trauma. The child is actively convulsing on arrival. Airway is patent. Breathing is adequate. IV access has not yet been established. Blood glucose is not yet checked. What is the most appropriate next step in the management? And your time starts now.
So, sir, midazolam spray. Yes, yes, sir,
You have to be specific. What spray?
Sir,
Spray is fine, but what spray?
IV access is not, blood glucose is not yet checked, and midazolam spray airway and breathing ये करेंगे, oxygen
One
देंगे.
step you have to mention. One step. One step.
Oh.
It is not multiple steps. Think and tell.
Blood glucose is not yet checked.
I think time is done. I would give you partial
rectal
credit.
diaphragm.
Yes, but I will have to. Bablu, time is over now.
Yes, sir. Yes, sir. It's been almost 15 20 seconds.
Time got over. We'll have to give you partial credit in this because what happened was within the time you answered one answer which was correct, but it was not the complete thing. Midazolam spray is not the appropriate term. We are pediatricians. We have to use proper term. Midazolam nasal route or buccal midazolam or rectal diazepam has to be given to the patient. Dose is not important. Checking for blood glucose is not, it is needed, but blood glucose is not yet checked. They are asking what is the immediate next step in management in such a GTCS patient where there is no apparent history of, it could be hypoglycemia, but the immediate next step, if you follow all the protocols, including the ones given by ILAE, they say if IV access is not possible and you feel blood glucose testing is not immediately needed, there is no evidence mentioned in the risk factor, you have to go for buccal or nasal midazolam or rectal diazepam. But you did say buccal midazolam before that, so we will give you credit for that as well. I'm being a bit liberal, and for others, I will be liberal with you as well. Don't worry. So Pablo, please give full credit to him. Although for future, I would say do not use non-scientific terms. You have to use scientific terms. Do not say injection of a particular drug. You have to tell intramuscular, subcutaneous, IV, nasal, oral, rectal. It has to be specific. Otherwise, you only get partial credit for the question. Okay.
Full 10 marks, right, sir?
Full 10 marks, yes. Moving to Dr. Rohan now. Dr. Rohan, your question
Yes,
comes
sir.
up now. A 10-year-old child with meningitis develops sudden bradycardia, hypertension, and irregular breathing. He is found to have a GCS score of 7. His pupils are otherwise reactive, and there is no UMN sign yet. Fundus shows mild papilledema. What is the immediate intervention to do in this child?
Your time starts now.
Your time starts now.
Five, 4, 3. Time up.
Okay. Rohan, let us summarize here. Meningitis patient. Can you see the Cushing triad? Bradycardia, hypertension, irregular breathing. There is also papilledema. Anyone else wants to answer this? We are dealing with raised ICP. You will not get
It was
credit, but if anyone wants to answer this.
hypertonic saline and intubation.
No, immediate can be one. It cannot be multiple things. That is not the...
Intubation. Urgent intubation.
Yes, it will be intubation. Reason being, any raised ICP patient with Glasgow coma scale less than 8 or patient already presenting to you with fixed unequal pupils with decorticate decerebrate rigidity, first you have to secure airway, plus also perform hyperventilation for a few minutes before osmotic therapy can be initiated in the patient. So immediate intervention, intubate due to low GCS, followed by osmotic therapy for raised ICP. Nobody will ask you to pick between mannitol versus hypertonic saline, although you will prefer hypertonic saline if the patient already has some acute kidney injury kind of condition. So answer to this question is intubate due to low GCS. Many of you will be seeing these patients and many of you will get similar scenarios tomorrow when you prepare for your fellowship or entrance exams for super specialty. So please go through them. They are based upon real life scenarios. So unfortunately, Dr. Rohan will not get credit in this. Bablu, you can summarize this course now. What is the total score?
After 3 rounds, Dr. Anuja is on 25, sir. Dr. Bairo is on 25. Dr. Mrityunjaya is on 15. And Dr. Rohan is on 15.
Yes. So, ma'am, my round is done. Please take over. Aparna, ma'am.
Yep. So yes, now we'll move on to, something which is visual. So this is going to be the visual round where we are going to have
Rohan,
image-based clues. So in this round, again, there will be one question asked to each of you. And maybe we'll begin now with Dr. Rohan in reverse order, just to, for a change. So each question is going to have...
Ma'am, Dr. Rohan just called. I think some network issue. He logged out. So we'll go in the sequence order.
Okay. Yeah, then we'll go in the regular sequence. Fine. So each question is going to have two parts. One would involve identification of the image, for which you get 5 marks. And the second part would be some question related to what you have identified in the image. And we are going to accept the second part only, obviously, if you answer or identify the image, which is the first part. So getting the first part is mandatory for getting the second part right. And if you get both of them right, you're going to score 10 marks. So all the best to all of you, and we'll begin with Dr. Anuja. Are you ready?
Yes, ma'am.
Dr. Anuja, are you ready? Can you unmute? Yes.
Yes,
So I hope you're able to
yes.
see the screen well, because this is a visual. Yeah. So a 7-day-old newborn born by third-degree consanguineous marriage who had normal antenatal, perinatal, and postnatal history, full term, by normal vaginal delivery with a birth weight of 3.2 kg, cried immediately after birth. On day 6, the nurse noticed poor feeding, few episodes of abnormal flexion movement of the upper limbs which were repetitive and were associated with tachycardia, suggestive of seizures. Blood markers, C-reactive protein and procalcitonin were normal. CSF analysis was normal as well. A suspicion of inborn errors of metabolism was made, and ammonia, lactate, ABG, GCMS, TMS were sent. The neuroimaging was done, and the images are going to be shown. I'll just show the image to you and ask the next 2 questions. These are the images from the MRI brain. What is the most likely diagnosis? First part. And what is the most appropriate next step in the diagnosis? Your time, 10 seconds, begins now.
Maple syrup urine disease.
Time
Okay,
up.
second part.
Ma'am, what was the second part?
What is the most appropriate immediate step in the management? Okay. I think we'll give you 5 marks, Dr. Anuja, for the first part. So Karthik, please note down 5 marks.
Yes, ma'am.
The diagnosis of maple syrup urine disease was spot on. So how did you make the diagnosis of maple syrup urine disease? You can share with us. Of course, this is completely informal. You don't get additional marks for it.
Ma'am, because of
What did you see on the MRI? Yeah. Yes, go on, Anuja.
ma'am, because of the ammonia, lactate, and plasma amino acids.
Okay, so this is a term. But those reports obviously were pending. So what on the MRI gave you the clue that this is MSUD? Because I told you the TMS, ammonia, and plasma GCMS is all awaited.
Ma'am, showing edema.
Yeah. All right. So you actually made a very nice diagnosis. So the most important findings in the MRI are the diffusion restriction of these core regions, the posterior limb of internal capsule, thalamus, motor cortex, and brainstem. So you can see, if you go back and see, you can see that in the first image on the left hand, you have brightness involving the basal ganglia region. In the second image, you see that the brainstem is significantly involved. This is where the dentate nuclei and all the deep nuclei of the cerebellum and the brainstem are located. Again, you see involvement of the thalami. The fourth image, the lower left image, you can see there is extensive involvement of the posterior limb of the internal capsule. And then the next 2 images again show basal ganglia involvement and parts of the motor cortex. So this edema, as Dr. Anuja was trying to tell us, which reflects as diffusion restriction or hyperintensity in the MRI in these particular regions, is pretty characteristic and is called as myelin splitting edema, which is typically seen with maple syrup urine disease. So this is, as you all know, an inborn error of metabolism involving the branch chain amino acids. So having come so close to the diagnosis of MSUD, the steps that would have helped us in immediate stabilization would have included keeping the baby nil by mouth or restricting feeds, starting the baby on intravenous fluids, and arranging for rapid genetic sequencing so that you can confirm the diagnosis genetically. And one of the this condition, anybody, which is the vitamin, the B complex vitamin that is useful in MSUD? It is thiamine. High dose thiamine or vitamin B1 is used. Right. Okay, so Anuja, you get 5 marks on your visual round. Next question, Dr. Bairo, are you ready?
Yes, ma'am.
Okay. Here you go. A preterm 28 weeks, 1100-gram neonate is now 14 days old. The first neurosonogram was absolutely normal. The second neurosonogram on day 14 is showing this finding. And these are the images. What is the diagnosis? And name a risk factor for this condition. Time begins now. Keeping time, Karthik?
Yes, ma'am.
Periventricular leukomalacia, ma'am.
Can you come again?
Periventricular leukomalacia.
Can you try to be a little bit more specific? What type of periventricular leukomalacia? Okay, you want to answer the second part? Please indicate when time is up, Blue.
Time up, ma'am, already.
Okay, so within the first 10 seconds, I could hear Bairo say periventricular leukomalacia. We would have wanted to hear the word cystic periventricular leukomalacia because PVL or periventricular white matter injury in preterm infants has 2 common types. The less common but more severe type is the cystic type of PVL. The more common but less severe type is the diffuse white matter gliosis type of PVL. So here you can see clear-cut cystic spaces, hypoechogenic spaces on both sides, lateral to the lateral ventricles, both on the image A, which is a coronal image, and the image B, which is a parasagittal image. You can see on the sides of the lateral ventricles, you see lot of cystic cavitary spaces, especially in the posterior part of the cerebral cortex. And this is cystic PVL. But since you said PVL, I think we should give you 5 marks. And two risk factors for PVL. So PVL is the sequelae of antenatal or fetal hypoxia and sometimes very early postnatal hypoxia. This can be seen with chorioamnionitis, intrapartum, intrauterine infections, or it can be seen with hypoxia in the form of asphyxia, post-cardiac arrest, postnatal hypoxia, post-major cardiac surgery. And one of the important blood gas abnormalities that causes PVL is hypocarbia. When you have low carbon dioxide, you have cerebral vasospasm in preterm infants, leading to cerebral anoxia or ischemia, leading to cystic PVL. So since you didn't answer the second part, we'll give you 5 marks. So please mark 5 for Dr. Bairo. Third question, Dr. Mrityunjay. Are you ready?
Yes, ma'am.
Yeah. Here you go. A 11-year-old child developed rash, and she also complained of generalized acute abdominal pain and mild joint pain. This is the scenario. This is the appearance of the rash. So the questions to you are, what is the most likely diagnosis? What are the other components of this condition? You can mention any two. Time starts now.
HS, Helen circle purpura.
Okay.
So what is and other components non palpable other what are the other components of this condition? And from
Time up.
MAHA.
I did hear Henox condyline purpura, which is quite right. So HSP or Henox condyline purpura is spot on. That is the diagnosis. This is a condition characterized by non-blanchable purpura and GI manifestations in the form of acute abdominal pain, intussusception. There could be gut ischemia, arthropathy or joint involvement, and renal involvement in the form of nephritis, nephrotic syndrome, and rarely up to around 5% may progress to acute or chronic renal failure. So in the additional manifestations, I could only hear the term purpura, but this was something that was already visible in the image. So we wanted you to say some of the additional manifestations, either the renal manifestations or the gut manifestations. So I think we can't give you the second part, but we'll give you 5 marks for the identification of HSP, which is one of the commonest vasculitis conditions that we see in children. So we'll move on to the last question. Has Dr. Rohan come back?
Yes, ma'am. Ma'am, how many marks should I give to Mrityunjay? 5? Or?
5. He gets 5 for identification of Henox condyline purpura.
Okay.
But for the other two parts, because he only said rash, which was already seen, we are not going to give him marks.
Noted.
We wanted any of the other two manifestations out of the 4. Okay? Yes. Dr. Rohan, is he
Yes.
here?
Yes.
Yeah. Rohan, please say yes loudly so that I know you're here. Karthik, is Dr. Rohan
Yes,
here?
ma'am.
Can you confirm?
Dr. Rohan?
Okay.
Yes.
So Rohan, unmute
ma'am.
yourself. 2-year-old child came with brief history of fever and
Yes, ma'am.
rapid worsening sensorium requiring intubation, shock requiring
Yes, ma'am.
inotropes. He developed this kind of rash.
Yes.
Fever, rapidly worsening sensorium requiring intubation and shock. This is the image. What is the most likely infection causing this condition? And which is the antibiotic of choice? Your time starts now, Rohan. This is a 2-year child who came with rapid worsening sensorium. Yes? Come again?
Meningococcus. Meningococcus, ma'am.
Okay. Since you said the first part.
Meningococcus,
Do you want to attempt the second part?
And ceftriaxone, ma'am.
Excellent.
Ceftriaxone.
Excellent. meningococcal septicemia or meningococcemia secondary to Neisseria meningitis is the infection that we are dealing with, which tends to present with purpura fulminans, rapid deterioration in sensorium, shock, and the drug of choice would be IV, third generation cephalosporin ceftriaxone is bang on. So you get 5 plus 5, 10 marks. I have an additional question for all of you. Any of you can answer this, but you don't get marks for answering this. There is a term 2.9 kilo neonate presenting with poor feeding for 8 hours. The baby is currently 8th day of life, and this baby presents to you with an acute onset history of poor feeding. On examination, the baby is drowsy, cold, CRT is prolonged at 5 seconds. The baby is tachycardic with heart rate of 190 per minute. On examination, you don't find any cardiac murmur. Neither is there any organomegaly on per abdomen examination, and there are no features suggestive of a congenital heart disease. The ultrasound of this baby shows Mullerian structures, but this is the appearance of the external genitalia. What is the likely condition? And what common
Congenital
enzyme
adrenal
defect
hyperplasia.
manifests with this? Very good. Congenital adrenal hyperplasia. And what is the
hyperplasia.
commonest
21
cause?
hydroxylase deficiency.
21 hydroxylase.
21
Very good.
alpha
21 alpha hydroxylase is the
hydroxylase.
commonest enzyme causing CAH. What is the antenatal management that is advised if we had diagnosed this in the antenatal period? Let's say if there's a family history, previous baby with CAH. So what is the antenatal management?
Steroid for
Yes,
male babies
antenatal
and
dexamethasone treatment.
dexamethasone for male
Yeah,
mother.
antenatal dexamethasone treatment for the mother can prevent virilization in a female baby with CAH. So
Female
this is
baby.
one of the rare conditions where gender determination is kind of medically or ethically permitted. So I think I'm done with my set of visual questions. I think there is one more extra question. This is a 14-month-old child with anemia, hemoglobin of 6.3 grams. 2 transfusions have been received, one at 6 months and one at 10 months, and this is a peripheral smear. So what is the underlying diagnosis? Name 2 characteristic findings in the peripheral smear. So what is the characteristic
HS, ma'am.
finding that you see in the peripheral smear? Anyone?
Hereditary
Peripheral
spherocytosis.
cytosis.
Hereditary spherocytosis.
So what you actually see is you have plenty of target cells. So this is beta thalassemia most likely from the history, and the blood smears in peripheral smears in beta thalassemia can show microcytic hypochromia, target cells, basophilic stippling, and fragmented RBCs. You see all the findings of hemolysis, and sometimes it can be confusing from iron deficiency anemia, because in both these pictures you can see microcytic hypochromic anemia. But how do you differentiate between the two? So it is an iron deficiency anemia that you get a greater variability in the RBC indices, whereas in beta thalassemia you get a fairly consistent appearance of microcytes and hypochromic cells, and you see typical target cells, basophilic stippling. So I think with that I'll hand over back to Dr. Sandeep for the next round.
After round 4, the scores are Dr. Anuja is on 30, Dr. Bhairav Singh is on 30, Dr. Mrityunjay is on 20, Dr. Rohan is on 25.
Lovely. So we are going ahead nicely. Without wasting any time, let us move into the world of identification, identifying the syndrome. The syndrome round will have, again, Bablu, it will have 5 marks each,
Okay,
because there will be no clinical scenario here. It is going to be a very typical clinical picture. And below the picture, there will be just 2 points mentioned or 3 points mentioned, which are characteristic or clues for additional things. So you have to basically look at the image, correlate with the 2 clues given or 3 clues given at the bottom of the image, and tell the diagnosis. Nothing else, just the diagnosis. 10 seconds allowed after showing the image, and your time will start immediately after the image is shown to you. So, Bablu, I will immediately say time starts now. You start counting from there. I will not be saying out the question because there is no question here. So, Dr. Anuja, are you ready?
Yes.
Sir, before starting, once again,
Yes.
I humbly request the participant to not to take their eye contact from the screen. If I observe anyone doing that, I will immediately disqualify.
Yes.
I'm sorry to
The
say this.
number will
Thank
be cut, and Bablu is Karthik is very strict in this. He will not listen to us also. So I hope you are all compliant with it, right? So let us start. So Dr. Anuja, I am going to show the first question to you, first image to you. Look at this image, and your time starts now.
Sir, CDLS syndrome,
Tell the full form, please.
Cornelia de Lange syndrome.
Yes, absolutely right. Absolutely right. Because you said the short form initially, that is what I was saying, but you answered it correctly. This is a child with cyanophris. Cyanophris means the eyebrows are meeting in the center. They also have a higher arch, very similar to how Shah Rukh Khan has. No, Shah Rukh Khan does not have any syndrome, but the arch is on the higher side like this. This is what you call as arched eyebrows. You can see this photograph. They also have upturning of the nasal apex. And generally, these people, when they become older, all the nasal hair is also visible, which is not a pleasant sight. They also have very prominent eyelashes. Apart from that, they have developmental delay of varying degrees. They have congenital heart disease. They have feeding difficulties. They 60 to 70% of them have some degree of reflux. And by the time they reach adolescent period, virtually all of them require GERD therapy or, GI consultation for the persistent ulcer related problems. So this is a patient of Cornelia de Lange syndrome. So absolutely rightly answered. You get full 5 marks credit in the question. Moving over to second candidate of ours, Dr. Bhairon. Dr. Bhairon, you are ready?
Yes, sir.
Okay. So your time starts now. This is your image.
Time starts.
Sir, Menke disease.
Why do you think so? Answer is correct, but why do you think so?
Sir, Kenki hair.
Kinky hair with alopecia, male child, delayed development, and hair microscopy is showing fracturing of the hair shaft. Trichorexis nodosa. All of this pointing towards a diagnosis of Menkes disease, also called as Menkes kinky hair syndrome, ATP7A gene mutation. These patients are X-linked recessive, so predominantly occurring in males. Absolutely rightly answered. You get full credit here as well. Uh, Dr. Bhairon gets full credit. Karthik, please note.
Yes or no?
Third, we move to round number 3. Dr. Mrityunjay, you are ready?
Yes, sir.
So showing you the image, and the image comes up now.
Five, 3, 2, 1.
Mm,
Time up.
Congenital. Mm,
Raised alpha, raised,
Angelman syndrome.
no, raised alpha fetoprotein, indicative of hepatoblastoma. Ear creases are present. You can also notice that this child is having a large tongue which is protruding, and the left side of the body is slightly enlarged. Anyone wants to give the diagnosis here? You will not get credit, although. Anyone wants to volunteer? Dear friends, this is Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome has features like hemihypertrophy, one half of the body is big, macroglossia, large tongue, omphalocele, increased risk of malignancy. Most common malignancy is Wilms tumor. Second most common malignancy is hepatoblastoma. That is why these patients require serial ultrasounds, annual ultrasounds, as well as annual alpha fetoprotein assessment, at least in the first decade of life. They are also prone to get hypoglycemia because they have hyperinsulinism. Beckwith-Wiedemann syndrome has a varied genetics, and some variants of Beckwith-Wiedemann also show association with uniparental disomy. So this is a very characteristic image. In fact, I would say this image very similar to one of the images shown in one of the department assessment for INISS, as I was told by one of your seniors and my student. So this is a very similar image. So, and it is freely available on various textbooks and Google search also you can find it. So answer is Beckwith-Weidman syndrome. Unfortunately, Mrityunjay doesn't get the credit for this. And moving over to Dr. Rohan. Dr. Rohan, you are ready?
Yes, sir.
So fourth image coming up your way, and the fourth image is your time starts now.
Four, three, two, one. Time up.
Okay, this could be multiple things, but the most likely syndrome, craniosynostosis is there. You can see
The
that there is
Apert syndrome.
there is strabismus and normal finger. What were you saying? Sorry.
Apert syndrome.
No. Apert syndrome will have syndactyly, mitten hands.
No.
Normal fingers rules out Apert syndrome. The second syndrome, which is a close DD and very common, that is Crouzon syndrome. Crouzon. Sometimes Carpenter and Pfeiffer can have a similar presentation, but again, strabismus and squint will not be as prominent in them. The proptosis will not be as prominent in them as it is in Crouzon syndrome. So answer to this question is Crouzon syndrome. Unfortunately, we do not get any credit here as well. So, Bablu, please summarize the scores at the end of round 5.
After round 5, Dr. Anuja and Dr. Bairo on same score, sir, 35-35. And Mrityunjay is on 20 and Rohan is on 25.
24. Okay. Moving over to the last round. Ma'am, please take over. Last round.
So you have an opportunity in this last round to score up to 25 marks, and this can be, kind of, yeah, it can change the entire, horizon of the quiz. So I wish all of you the very best. So I'll begin with, should I begin with Dr. Anuja as per the order?
Your call, man. Your
Or
call,
should I
man.
begin with, can you tell me the scores again?
Anu,
Yeah, Anuja at
sorry. Anuja, Dr. Anuja is on 35, ma'am. Dr. Bairo is on 35. Dr. Mrityunjay is on 20. And Dr. Rohan is on 25.
25. Okay, I'm going to begin with Dr. Mrityunjay. Right?
Okay.
So this is a chance for you to score 25 marks. So Dr. Mrityunjay, please be ready. Please unmute
Yes,
yourself.
yes, yes, ma'am.
Let me share the presentation. So each person is going to get total of 5 marks, and the timer can start the time of 30 seconds from the time you start reading the question. So all participants, please try to answer as many questions as you know, because there are no negative marks. And although you can't pass to each other, you can pass to yourself and you can come back to the question as I previously said. So the maximum score you can score secure is 25. All the best. I'll begin with you, Dr. Mrityunjay. Expand GINA.
Global Initiative of next guideline for asthma initiative.
Okay. Second question, what is the name for the standard reporting guideline for meta-analysis? If you don't want to answer,
Pass.
just pass. Say pass. Okay.
Pass.
I heard
Pass.
pass. The age at which a child can understand gender differentiation is 4 years. True or false?
True.
You said true. Okay. Eye of tiger sign in MRI is seen with.
Tiger is tuberous sclerosis.
Tuberous sclerosis is incorrect. Identify this pedigree. How many seconds left?
4, 3, 2, One. Done.
Okay, so we didn't hear any answer for the last question. So Mrityunjay, well done. Your first question was Global Initiative for Asthma. Although you fumbled, said some guideline in between, I think we should give you because you were almost there. GINA is Global Initiative for Asthma. These are indeed guidelines from the GINA body for standard guidelines for the treatment of bronchial asthma. So 5 marks for that. The second question was the standard reporting guidelines for meta-analysis. So as you know, we have reporting guidelines for various types of studies, and for systematic reviews and meta-analysis, we use something called PRISMA, which is preferred reporting items for systematic reviews and meta-analysis. It's like a checklist of number of items based on which you assess or you critically appraise the quality of a meta-analysis. The next question was, we said that the time for a child, the age at which the child usually is able to differentiate gender is 4 years. You said true, which is incorrect. The answer is in fact false because it is 3 years. The eye of tiger sign is seen with Halovidan-Spatz disease or PCAN, which is pantothenate kinase associated neurodegeneration. This is a typical MRI finding in Halovidan-Spatz disease. Again, I heard tuberous sclerosis, which is incorrect, so we can't give you this one. The last item which we displayed was a pedigree image, which refers to monozygotic twins. So you can see these are identical twins, and you see a small band connecting the two. These are the pedigree symbol of monozygotic twins. So, you could not do that as well. So I think you get 5 marks for answering GINA, which is Global Initiative for Asthma. Well done, Dr. Mrityunjay. So 5 marks to him. We'll next move on to Dr. Rohan, who is on 25.
Yes, ma'am.
Rohan, are you ready?
Yes, ma'am.
So here you go. With respect to adoption, what is PAP? Time begins now, 30 seconds. What is PAP?
Next, ma'am.
You want to take it or you want to pass?
Pass, ma'am.
Okay. What is the standard checklist for reporting a randomized control trial? An RCT. Just like the PRISMA was for meta-analysis, what is the standard checklist for RCT? If you do
Pass,
not
ma'am.
want to take it, you can say pass. So that we go to the next question.
Ma'am, total
Unless you
sleep
say pass, I
duration.
can't go to the next question.
Ma'am, pass, ma'am.
Okay. Total sleep duration in hours for a 2-month-old infant is 14 to 16 hours per day. True or
True, ma'am.
false?
True, ma'am.
True. Fourth
No,
question,
time.
radiographic image of the skull shows classic crooked appearance in which condition?
You cut. Ma'am, pass, ma'am.
Okay. Identify this pedigree image.
Hemizygous, ma'am. Ma'am, can I go to
Hemizygous.
the
You can go to
can
any
I
of the
go?
questions you want to.
Question number 1. Pre-adoptive parents in
Pre
parents.
Pre-adoptive parents. Okay. Please tell me when time is up, team.
Yeah, I already announced my time.
Okay. Okay. So the first question was prospective adoptive parents. So this is a term that is used in adoption. You said pre-adoptive parents. So I'm not sure. I don't think we should give it for that because it's clearly prospective adoptive parents. The standardized reporting checklist for a randomized controlled trial is a consort statement, which is consolidated standards of reporting trials. So this kind of reports, it's a checklist that looks into various aspects of our RCT, like the randomization sequence, allocation concealment, blinding, etc., to assess the rigor of our RCT. The next question was total sleep duration in hours for a 2-month infant is 14 to 16 hours. You said true, and that is correct. So 5 marks for this one. And crooked appearance in the X-ray is seen with thalassemia. So that is because of the extramedullary hematopoiesis, you get this crooked appearance. The last one, I heard you saying hemizygous. This is actually to indicate carrier, gender not specified, very specific entity. So again, this is something I don't think we can give it. So we'll give 5 marks again to Dr. Rohan. He got the third question right, true, for number of hours of sleep duration. So Dr. Rohan, you get 5 marks in rapid fire. Can we move now to Dr. Bairo? Are you ready?
Yes, ma'am.
Okay. Your time begins now. Expand ACVIP vaccination schedule.
Take it later, ma'am.
Sorry, I couldn't hear.
Next question. Forward to next question, ma'am.
Acha,
saying
forgotten.
pass.
You can say
No,
pass.
yeah.
Yes, ma'am.
What is the standard checklist for reporting an observational trial? If you want to come back later, just say pass.
Stop, ma'am.
Stop is, yeah, stop is right. Handedness is achieved by 15 months. True or false?
False, ma'am.
False. I heard false. Mutations in ATP7A are primarily associated with Menkes disease. What is mutation in ATP7B associated with?
Ma'am, Wilson disease.
Wilson disease, that's right. Identify this pedigree symbol.
Ma'am, question number 1, expanded.
ACVIP.
Advisory Committee on Vaccine and Immunization Practice.
Time up, ma'am.
Okay. Do you want to go for the fifth one?
Ma'am, pass. No.
Okay. All right. So I think you did very well, Dr. Bairo. Advisory Committee on Vaccines and Immunization Practices is indeed ACVIP, which gives us the vaccination schedule. Strobe, you rightly answered Strobe. I too didn't ask you for the expansion, and it's of course a very lengthy one. Strengthening the reporting of observational studies in epidemiology is what Strobe stands for. It is a checklist, standard reporting checklist for reporting observational trials. The third one, you said handedness is achieved by 15 months. You said false. False is correct. So handedness is not achieved by 15 months. It is achieved only by 3 years. That is why if you see early handedness before 3 years, it might be a sign of hemiparesis and it should be evaluated seriously. Mutations in ATP7A are associated with Wilson's disease indeed. And the last pedigree which you did not attempt was actually the pedigree for adoption in to the family. So you also have pedigree symbol for adopted out. This is for adopted in. So I think you get 1, 2, 3, and 4. So 4 to 5, 20 marks for Bairo. Please add 20 for Dr. Bairo. Okay. Dr. Anuja. So this is your chance to top the quiz. So you and Dr. Bairo are both on 35. He has now secured 55. And if you get 5 questions right, you win the quiz. If you get 4, you both kind of tie for the same position. And if you get 3, then Bairo wins the quiz. So are you ready?
Yes, ma'am.
All the best. Expand KDIGO. KDIGO.
Ma'am, kidney disease improving global outcome.
Right. What is the standard checklist for reporting the protocol of an interventional trial?
Ma'am, spirit.
You said spirit. Girls are usually later than boys in achieving bladder control at night. True or false?
False.
False. Cave ring due to deposition of copper is seen in which layer of the eye? Which membrane of the cornea?
Ma'am, Descemet membrane.
Very good. Descemet's membrane. Identify this pedigree.
Um, Ma'am, autosomal recessive.
Time up,
I
ma'am.
heard autosomal recessive. Okay. All right. So KDIGO was indeed kidney disease improving global outcome. KDIGO has given the classification of acute kidney injury. Spirit, you rightly said, is the standard reporting item for interventional trials, standard protocol items, recommendations for interventional trial framework. The third one, girls are usually later than boys in achieving bladder control is false. Girls usually achieve bladder control by 4 years, in contrast to boys who achieve by 5 years. So they usually achieve earlier. Again, you answered it right. Case of Fleischer ring seen in Wilson's disease is due to copper deposition in the Descendens membrane of the cornea, which is also right. So the last pedigree was couples with no children by choice. So you could see there's a husband, wife, and then there is generally where you expect a child, a square for a boy or a circle for a girl. Instead, there is a horizontal line. So this is a pedigree symbol for no children by choice, reason unknown. So again, Dr. Anuja gets 4 questions right to get 20 marks. 20 marks to her as well. So that finishes rapid fire. So I think we are in for an interesting time.
Yes.
So we are done with all the rounds.
Yes, ma'am. Can we
Can
do
we have
an
the final score?
tiebreaker, ma'am? Ma'am,
Hello?
Karthik here. Ma'am, Karthik here.
Yes, Karthik. Yeah.
Dr. Anuja and Dr. Bairo Singh are on tie. Can we do a tiebreaker? Do you have any question, ma'am? Ma'am, you're on mute. Ma'am, you're on mute.
Yeah. I do have some additional questions. So, Dr. Sandeep, we are in for a tie.
Yes, ma'am.
Sandeep.
Ma'am,
Yeah.
nay, I'm here. I'm here. Yes, ma'am. Ma'am, do you have a question? Like my question is there, but it's on the simpler side. So there is a good possibility the way they both are performing, it will still be a tie. So
Okay.
similar pattern, as we had discussed, can we use one of those?
Okay. I do have a whole set of rapid fire 5 questions. So what do we do? I mean, shall we display 5 questions and see the best of 5? One second. Right. I think what we will do is we will request both of you to unmute yourselves, Anuja and Bairo. I'm not going to display any questions. I'm just going to read the question aloud, and whichever of you is going to answer the question gets the score. And I'm going to read 3 questions. There will not be any time, but whichever of you answers first, we're going to take that answer. Is that okay for both of you?
Okay,
Right?
ma'am.
Okay. So let me begin. Are you both ready? Are you both listening?
Okay, ma'am. Yes, ma'am.
So you won't see any question on the screen. So please listen to me attentively. First question. Both of you, please unmute yourselves.
Okay.
The name given to the reporting standards designed to improve the quality of research involving animals.
Ma'am, please repeat.
The name given to the reporting standards designed to improve the quality and transparency of research involving animals.
Ma'am, arrive guideline.
Can you expand it?
Animal research reporting in vivo experiment.
That is right. Okay, we have the best of 3 questions. So that was the first question. Please note down, Dr. Anuja answered the first question.
Yes.
Okay, here's the second question. Which aneuploidy is associated with low levels of MSAFP, which is maternal serum alpha fetoprotein, low levels of HCG, unconjugated estriol, and inhibin. Basically, low levels of all of these. Yes. You want me to repeat?
Yes, ma'am. Can you repeat?
Which aneuploidy is associated with low levels of maternal serum AFP, HCG, unconjugated estriol, and inhibin?
Triple.
Okay, I didn't hear anybody answering. So I'm going to reveal the answer now. None of you get the scores for this. The answer is trisomy 18. So trisomy 18 or Edwards is associated with low levels of all these markers. So this is the last question in the best of three. Are both of you ready?
Yes, ma'am.
Name the formula used to calculate the number needed to treat. Which formula is used to calculate the number needed to treat? This is a term often used in statistics. NNT, number needed to treat.
Absolute risk reduction, 1 by absolute risk reduction.
Excellent. 1 by absolute risk reduction. That is indeed the formula used for calculating number needed to treat. So that finishes the best of three in rapid fire. I mean, in the tiebreaker round. So I think we have a clear winner. Dr. Anuja answered 2 of these questions. She answered the ARRIVE guidelines for animal studies, the standard reporting checklist, and NNT is 1 by absolute risk reduction. So I think we have a result at the end of tiebreaker, and I'll now hand over back to Dr. Sandeep Sharma and to the organizers from DocTutorials. I think we have the final score. So we can give 10 marks additional to
Yes,
Dr. Anuja.
Karthik, please announce the final scores.
Yes, sir. I'm sharing it on the screen, sir. Hope everyone can see my screen. Can you see the scores, sir?
Yes.
Yeah.
Yes.
So Anuja, first round, I'm taking through the round wise. Anuja, round 1, 5. Bhairav, round 1, 5. Mrityunjay, round 1, 5. Rohan, round 1, 5. And round 2, Anuja, 10. Bhairav, 10. Mrityunjay, unfortunately, didn't score. Rohan scored 10. Round 3, Anuja, 10. Bhairav, 10. Mrityunjay, 10. And Rohan, unfortunately, didn't score. And round 4, Anuja 5, Bhairav 5, Mrityunjay 5, and Rohan scored massively 10. And round 5, Anuja 5, Bhairav 5, Mrityunjay and Rohan didn't score. And in round 6, Anuja and Bhairav scored same, and Mrityunjay and Rohan scored same. And tiebreaker, Anuja was on after tiebreaker, Anuja was on top with 10 marks, and Bhairav is on second spot, and okay.
So congratulations.
Rohan was on third position.
So I think as we always keep hearing, competitions are not about winning. It is a spirit of participation that is most important. And in quiz competitions, especially, it's not just the spirit of participation, it's the spirit of learning. There's so much of learning that comes by participating, by even listening to a quiz. And for all of us, every time that we prepare questions for a quiz, there is just as much learning. So congratulations to the winner, the runner-up. Congratulations to all the participants. You all have made it to the second round, the final round of the DNA quiz, which itself has required a lot of preparation and has come from a lot of hard work. So I hope this was a kind of motivation for all of you to keep reading and keep learning. And hearty congratulations and wish you best wishes for all your further endeavors in this process, in this journey of learning. And hope you enjoy and flourish in your career of pediatrics, not just now and in forever in your future. All the very best. And Dr. Sandeep, for your
Congratulations.
words.
Congratulations, everyone. I think all four of them have done excellent. They did equally well in the prelim round as well. And but today, yes, somebody had to win, somebody had to lose. But end of the day, all of you have performed excellently well. And I'm so really proud of you. And I'm quite sure you all are going to benefit from it. And we'll be in touch. The bigger game is becoming a better pediatrician. That is something I'm sure ma'am will also agree that we are all working towards still trying to be a better pediatrician because that journey is never going to stop. But you're on to it, and you guys and you girls, you are doing great job. So, ma'am, closing comments, and Karthik can also tell about the like the winner thing and the details of the thing. Karthik.
Happy to see everyone participated very actively, and everyone is a winner. No one is a loser here, and you all are inspiration to the upcoming your fellow residents and all. Congratulations and all the best for you.
So all the best and congratulations once again, and hope to keep meeting you in the upcoming sessions. Bye bye and good evening.
Yeah. Before ending, once again, and I'm announcing the ranks. Top Anuja is on top, and followed by Bhairav, and then followed by Rohan, and then followed by everything.
Yes. So good night, everyone, and take care. And details of the winners and everything will be intimated to you.
Yeah.
Separately. Yeah.
Thank you, Dr. Sandeep sir. Thank you, Dr. Aparna ma'am, for your time and
Thank you, ma'am. Thank you.
Lovely.
Thank you, sir.
Thank you, everyone. Bye bye.
Thank you, dear doctors. Thank you so much for active participants. Thank you. Bye, doctor. Good night.